Okay, good afternoon, everyone. Good afternoon. This is your lucky moment. This is where you get to be the star. So right now we are going to have the Ask the Expert panel. So I am going to call for my experts to come up front, and then you will be able to ask questions. If you are mobile and can come forward to ask your question, I will ask you to step forward and to the microphone and ask your question. If you would need for me to come to you, just raise your hand and I will come to you with the microphone. But those that can come to me, I will have you come to me. That will make it easier for sound and video. So first on our panel, I have Megan Gutierrez. Let's have a round of applause for Megan. They will each introduce themselves to the entire group, and then you'll be able to ask your questions of whomever you would like to. Next, I have Dr. Stephen Jensick. Ooh, he brought his own crew. It's always good to have Lisa cheering for you. She was cheering for me at the transplant games, and I won a bronze medal. We also have Elaine Frank. Thank you. And then we have Dr. David Banyan. So I will give them each the mic to introduce themselves, and then we'll ask questions. We'll try to stump the experts, but it won't be possible.
Hi, everybody. I'm Megan Gutierrez, transplant dietitian at Northwestern.
Stephen Jensick, one of the kidney transplant surgeons at Rush.
Elaine Frank, financial coordinator at Loyola.
My name's David Banyan. I'm a hospital and transplant psychiatrist at Rush University Medical Center.
I'm from Northwestern. I'm the transplant dietitian. Yep.
We also have Sonia Vasquez. I didn't know Sonia was still here. Thank you.
Hi, I'm Sonia Vasquez. I'm one of the transplant coordinators for the pre and the post patients at Advocate Christ Medical Center.
Awesome, awesome. So, who wants to be the first? Who has a burning question? Come on, Larry, come up front. I know you think you don't need the mic, but we're video recording this, so.
I have read articles online, possibly associated with the CDC, that indicate that kidney patients in 3 studies were able to reverse kidney function loss by virtue of the industrial solvent DMSO. Have you heard anything about those studies? Or do you give credence to DMSO?
The question is about DMSO. It stands for dimethyl sulfoxide. It's a solvent. It's very soluble in the skin. And frequently things that are dissolved in DMSO, if a person touches it, will be absorbed through the skin. But I'm unaware of any particular benefit for patients with renal disease or post-transplant with this particular solvent. It's an industrial solvent, and probably should be studied very carefully before people are thinking of trying to use this, and I'm not even sure how they would use it. Sonia, have you ever heard of it? Or all right. Anybody else have any comments? All right.
She said she's a chemistry student, and they told her to use it with great care because it's a potent carcinogen. So they used it with great care. Okay, is there another question? Come on up, Kelly.
I've been hearing a lot about the supplements and everything. I think it depends on your body and what your levels are, because there was things that I could have taken that might have helped the problem at that point. But I think at that point you need to really stay in contact with your transplant team and your doctors, because your levels fluctuate a lot. And I didn't take any supplements unless the doctor gave it to me. The only thing that I did try, like I said earlier, was the cannabis lotion. But otherwise, I just followed everything that my transplant team and doctors have recommended. Like you said, supplements, you don't know what they all contain. And after learning some of them that might have helped a certain problem, might cause another problem in a different area and you're not aware of it. Just wanted to throw that out there.
So I think Larry does a lot of research. He's trying to slow the progression, reverse the progression of kidney disease. So he does a lot of research, but then he comes here and he asks questions of the experts to find out if there's any validity to that information. So we appreciate you for continuing your research and continuing to join us here. But definitely the best advice is to stay in touch with your physician and definitely ask those questions specifically of them. Ask those questions directly. Okay, Ms. Betty has a question.
The only thing what I'm going to say is that's why they give you a team when you get your transplant. I take nothing unless I bring it by my team. I don't care what it is. If I get a cold, I'm going to call them and see, if I can take this, because they are the experts and they know what you can take and what you can't. I mean, well, I'm old and I don't go online. So anything I tell you, go online, and remember, they give you a team. Ask your team before you take anything.
That's what, 14 years of experience talking? Thank you, Ms. Betty. Anybody else have a question? So I'm going to ask, because most of you weren't, okay, come forward. Come, because we need you to have it on the mic. Say it on the mic. Thank you.
I see more and more dialysis centers opening up. Is that telling us more and more people getting kidney problems, or what is it? Is the doctor? No problem, doctor. But is it something they are not telling us? Because more and more young people are going to dialysis now. What is it beyond? Is it something else other than high blood pressure? What else is affecting our kidneys?
Thank you, Dorothy. That's a great question. Who would like to take that one first?
The answer is the incidence of kidney failure increasing? Is this why there's the perception of more dialysis units being opened? And the answer is yes. And what's the cause of this? Primarily in this country, diabetes and high blood pressure. And this is not the first time anyone in this room has heard this. This is a national health urgency that really needs to be addressed. And this is responsible for the increased incidence of kidney failure in this country. Sonia, do you have?
One of the things that I have noticed over many years of working in transplant is that patients are getting better screened by their healthcare teams, and they're diagnosing diabetes and hypertension and renal disease a lot earlier than they would have in the past.
So what is important to know is that there are 30 million people in this country that have chronic kidney disease, and 96% of them don't know it. So what Sonia stated, that there are better screenings going on now. We, the National Kidney Foundation of Illinois, we have our Kidney Mobile, so we do preventative screenings all around the state of Illinois. So I would ask you all to encourage your friends and family to come out to our free kidney screenings and learn if they are in some stage of kidney failure, or if they have some stage of kidney disease, because the progression can be slowed or stopped if you know that you have it. You can change your habits, and that will make a difference. So I encourage everybody in this room to encourage other people when you leave here to get screened for kidney disease, because those dialysis centers are going up on every corner because more and more people are being diagnosed with kidney failure because they're too far along to stop the progression by the time it's diagnosed. There was another question here. I'll come to you.
Hi, I had a question about, I'm on hemodialysis, and I was given an order for an MRI with gadolinium. How do you feel about that? Because I guess there's NSF, nephrogenic systemic fibrosis, that I had a lung transplant also, that my pulmonologist was afraid that I could develop if I got the gadolinium. My internist ordered with the gadolinium, but my nephrologist was willing to override the hospital's policy of not giving gadolinium to someone on hemodialysis. So I just wanted to know what's the right thing to do, because they left the decision up to me. So I said no, I didn't want it because I was afraid.
So the question is about the safety of a certain kind of X-ray test, an MRI, for patients in kidney failure. So an MRI doesn't use regular X-ray dye, which has iodine. It uses a substance called gadolinium, which is excreted by the kidney. So patients with advanced kidney failure or patients on dialysis do not excrete the gadolinium after it's given for this test. The gadolinium can precipitate in the muscles and skin and cause a terrible problem with nephrogenic systemic fibrosis. It is a ghastly problem where the patients essentially become mummified and can't move. It's a terrible problem. And so this has been, people have been aware of this now for 10 or 15 years, and most radiologists, most imaging centers that do MRIs inquire very carefully about a patient's renal function. If a patient has normal kidney function, the gadolinium is excreted. If there are degrees of renal insufficiency, or particularly if somebody's on dialysis, then that's a test that has to be given very carefully. Sometimes they can do MRI without gadolinium, but the decision to do that test with or without gadolinium should be made by the nephrologists and the radiologists together. And so, without going into too much of your personal history, you said you had a lung transplant. I presume your kidney function is probably okay, and maybe that's why they ordered it. But certainly a nephrologist should be involved in that decision. They shouldn't leave the decision to you. That's not right. That's what we're supposed to do, is help patients with... All right, so this would be, I would be surprised if your nephrologist would okay this exam using gadolinium.
He said it would be okay as long as I went for 2 consecutive dialysis treatments, one that day following the MRI and then one the next day.
All right, well, that's probably good advice. The nephrologists are certainly better at assessing the risks to a patient for this kind of exam. But I think trust your nephrologist is probably giving you reasonable advice. But in the end, you have the right to turn this down if you have concerns.
Come on, Larry.
Given that the disparagement of the kidneys is often inflammation-based, why is it that many doctors and other scientists urge that vitamin C levels either be eliminated or curtailed, even though it's an anti-inflammatory.
Well, you certainly have very interesting questions, I must admit. I personally have never heard that vitamin C is contraindicated or has to be given in reduced dose for kidney patients. Somebody in the panel was, oh, I apologize.
That's okay.
All right. Maybe you'd be able to answer that with more detail?
Vitamin C is an antioxidant. So it's often recommended to patients on dialysis sometimes, and sometimes not. But it's water soluble. So what you don't need is excreted out, and in excess can cause diarrhea. So it's not something that everyone should just be walking around taking vitamin C supplements. It's really widely available in food, fruits and vegetables, and if you eat your 5 a day of fruits and vegetables, you can get a lot of vitamin C that way. So food first, then supplements, but not for vitamin C ideally, since it's so abundant.
Okay, so I have a question for Dr. Banyan. He talked to us about coping while you're waiting for transplant, and we got into also post-transplant coping as well. And so I want to ask Dr. Banyan to give us 5, maybe 2 pre-transplant coping mechanisms and 2 post-transplant.
Thank you for your question. I'm going to cheat a little bit and give you 4 and state that they are applicable both pre and post. So I hope to be concise, as we spoke at some length before. So the first one is a lot of people experience a loss of structure as their kidney disease progresses. So we're talking pre-transplant now. Because of the physical symptoms, perhaps other medical complications that arise, it's difficult to maintain employment or other activities, and so they're forced to withdraw. And that loss of structure can be very hurtful. It changes the way a person thinks about him or herself, and also changes how the family dynamics work. So I think working towards regaining some sort of structure, what are the ways in which one is able to invest one's time, and that's intimately tied to a restructuring actually of one's goals. Perhaps the goals have changed now because part of the goals now are probably an intense focus on health and well-being to an extent that was not needed before, but certainly is needed now. And those two are intimately tied together. And I think that that's very important, and that then is a segue into the third part, which is social engagement. That is activities. That could be hobbies. That means getting out of the house. That means having activities and time outside of the dialysis center. And going to dialysis is a time-consuming, especially, for example, if you have to wait on certain types of transportation. The more limitations that one has, the more time it takes out of the day. A lot of people don't feel well after it, but they tend to do better the following day. So it's really about restructuring, reorganizing, how to maintain social engagement, restructuring goals, making sure that if you're not able to do other things, that those energies and efforts and hopes are invested into other things, other goals. And the last is actually building upon the lecture given about nutrition and diet, which is critically important no matter what, but even more important if your body is not able to handle the metabolites and nutrition as it was. So maintaining a healthy weight, that actually all these things will set you up to do well in the post-transplant phase. You've gone through this journey, you've had to adapt to a condition. I often, with the patients that I work with, I am often consulted to treat patients or assess patients who suffer from major depression or anxiety disorders. And so we talk about this as a journey, and we also talk about the post-transplant phase not being a cure, but a trade-off. You are still going to have to do things that you would otherwise not have had to do if you had never had kidney disease. And often times the goal is we want to get better. We want to actually get back to the life that we had. But to some extent, in certain ways, that time is past, you can get off dialysis, you can do better, you can re-engage your life and feel better after transplant. But you also have to set yourself up with having that motivation, those goals, that structure. And oftentimes, if it's not there before, it can even be even harder after transplant, especially with sudden loss of your cohort or people or friends that you've made at dialysis, and suddenly that structure is then lost. So it's important, I think, to think about all these things as you go along the journey.
Thank you so much. Did anybody else have a question? Okay, I have another question before Larry comes, because Larry's questions are deep.
With the opioid use disorder and the prevalence that we're observing, across the country, I am curious in terms of if there have been studies, or are we seeing that amongst our renal patients, transplant and post-transplant, either from overprescribing or quote-unquote self-medicating through, I would say, abuse of medications.
I'm going to start, and then I'm going to ask Dr. Banyan to finish. But yes, that is a problem of increasing incidence in this country, and certainly with potential transplant patients, both before and then afterwards. And there have been reports that patients on chronic narcotics do not do as well post-transplant. And so the evaluation of this before transplant has become very important. And there are various, probably more details to this entire situation, both how to approach this as well as diagnose this. And I'm going to let Dr. Banyan talk about this, because this is probably a major part of his practice with us.
Thank you, Dr. Jensic. So this is a real issue. It's a serious issue. We know that individuals who are using narcotics beforehand, before going into a surgery, we're talking about kidney, but it could be something else, but it's a major surgery, will require a lot more narcotics, and they'll require it for a lot longer. That then, if they have a dependence before, that can make the issue worse. If they're just using recreationally or describe their use as that, which is very loose, okay, then it does put them at more risk. We have to think of narcotics from a neuropsychobiological point of view, and that it affects all systems. And so, and it has a tremendous impact on behavior. So part of the reason why opioid use disorder is so problematic is that aside from the lethality and mixing of the medications with other things, or accidental overdoses, or if use is, for example, purchasing oxys off the street, you don't know what you're getting. Things are cut with fentanyl, with other adulterants. Those can interact with the post-transplant medications. They can actually insult your organs. So it's a huge concern, and part of it also is that it diverts a person's attention. The withdrawal, which is a psychophysiologic withdrawal, meaning associated with intense cravings, dysphoria, meaning a bitter, unpleasant state of mood, drives people's attention to try to go to remedy it, and other things will fall to the wayside as their attention becomes intensely focused on dealing with that symptom. And maybe then they get lost to follow-up, they're not taking their medications as prescribed, and a lot of time it's not intended, but it is a consequence of getting involved and developing a substance use disorder. Hopefully I answered your question. I could talk about this for several hours, but I'll try to be concise.
I just want to add, I shouldn't say this, I should be embarrassed to say this, but 20 years ago, the surgeons were pretty blasé about patients who were taking narcotics. Well, just get them to the surgery and they need narcotics for a longer period of time. In retrospect, that was the wrong approach, and now the errors of that approach have been magnified by the increased incidence of this problem. So this is something that we're all taking a lot more serious than we did not that long ago in the past.
Okay, just a little commercial break. I want to remind everybody to fill out their surveys that are in your the orange bags that you got. Everybody, please make sure to fill out a survey and turn it in. It's really important so that we can continue to improve on our programs. So I wanted to ask the person who deals with funding transplants, can you tell us what is a major barrier to funding or getting a transplant paid for? Because I think a lot of people worry about that. And the beautiful thing is that you guys will, all of this has been videotaped, so if you were not in her session, you will be able to go back and watch it later if you missed any of these sessions.
Yeah, so not having adequate coverage is an issue. Some people come with just Medicare and they don't realize that Medicare doesn't pay 100% of your medication costs in your hospital visits. So the major barrier is not having adequate coverage. Second is continuity of coverage. You have to have the pre, the transplant, and the post. So it's not just one or two sessions that you have to go to. You have to have a continuity of all, from beginning all the way to the end. And the post care is also just as important as the transplant care. Did you want to say something?
Well, I was going to add a little bit to that. It's a common myth. People hear all the time stories. A patient had a transplant, did okay for 3 to 4 years, then lost the insurance, and nobody would pay for their insurance, and they lost the kidney. So that's kind of an oversimplification. I'm speaking for the Rush program, but I'll bet all the programs do this. If somebody at the end of 3 or 4 years, or whenever Medicare is going to run out, if somebody proacts with our program 2, 3, 4 months before the deadline and says, I'm going to need help, I'm going to have change, I'm going to have supplemental financing or some other alternative for the pills, we will work with them and they will get some sort of medicine and keep the kidney. It's the person who comes to our office at 2 minutes to 5 o'clock on Friday, when some of us are going home and others are going to a bar, I'm not going to say who's who, but and says, I've lost my insurance and haven't taken my medicine for a month. That person will lose the transplant. So yes, it's an ongoing ordeal, am I right, to maintain insurance for kidney transplant recipients, but the mechanisms for this support is there, and we urge you to use it in a proactive manner.
Yes, definitely have to be proactive all throughout.
This question goes along with that. That's why I shot my hand up. I don't know if you've noticed, but I'm sort of pushing for living donors, if you haven't picked up on that. So a question I've been asked, my experience was amazing at Loyola because I haven't paid anything. All it cost me was a kidney, and I really don't miss it. Just saying. So if people ask me if I'm a living donor, is it always covered by the recipients or the hospital? Is there ever an occasion where a donor ends up having to pay? Because I've been asked that.
So at Loyola, we never bill the donors. They're covered all the time. Even if they live in another state and they have to have some procedure in another state, we will pay that bill. We have a grant, so we just don't bill the patients. The insurance, we bill the recipient's insurance as long as they'll cover it, and after that, the donor is still never responsible for any of the bills.
Sonia, is the advocate program pretty much the same?
We are pretty much the same. The one thing with donors, though, if you start the donor process, and during the process they identify a health problem that was very specific to you, and you're not going to be able to continue with living donation, obviously that's going to be your own responsibility. Say, for example, you have an abnormal EKG and you need open heart surgery. Well, at that point, that's a little bit different.
Thank you for that clarity and those answers.
Hi, I've read something about plastic bottles and small pieces of plastic possibly damaging the kidneys. With the prevalence of plastic bottles, should I stop drinking water out of plastic bottles from now on.
No, I've never heard anything that the use of a beverage from a plastic bottle is bad for your health in any regard, particularly your kidney function. I know you're not supposed to use the same plastic bottle for years because some of the components will gradually leach out in the liquids, but having it for the first time, that's my understanding.
Thank you. You mentioned that you bill the recipient's insurance for the donor's expense. Does that impact their cap? Yes.
Insurance companies are doing away with that lifetime max, so there's really no max. But out-of-pocket costs, it does go to their out-of-pocket costs. So say you have $5,000 out-of-pocket costs. So your insurance gets billed. Say you have a $200 deductible that's applied towards that. That does not get billed to the recipient or the donor. That gets adjusted off. Thank you.
Given that the primary function of kidneys, other than protein processing, is to get waste out of the body, would you say that it's a significant strategy as a lifestyle to increase fiber intake, such as psyllium husk powder, in order to reduce the burden on the kidneys and take the lion's share of the waste out the intestinal canal?
And this is the last question.
And one of my favorite topics. Well, you know, it goes with eating. What goes in must come out. So, you know, your bowels are another way for your body to excrete waste products. And it's a detoxifying system, just much like your kidneys and your lungs and your liver are detoxifying for your body. So adding more fiber to your diet is going to add more bulk to your stools, which is definitely beneficial for the gut health, the microbiome in there, which has an impact on your immune system. And so it's just kind of like this cascading thing where it impacts all these beneficial things in your body and your mood. And so more fiber is better. And in terms of like waste detoxifying properties, benefits, yes. In terms of fiber, like promoting satiety and that feeling of fullness, to reduce your calorie intake, to lose weight, yes, benefits. So all good things with increasing fiber intake. The only downside is that it has to increase water intake as well, and that might be kind of a tricky thing with fluid restrictions. So constipation might be an issue. And yeah, a nice balance of fiber and water and regular bowel movements, making sure that things are moving along on a daily basis.
So it sounds like that is good advice for someone who is trying to slow the progression of kidney disease, but not necessarily for someone who is on dialysis because of the fluid restrictions. So, okay, well, I want to thank our panel. Let's have a round of applause for our panel. Thank you guys so much for coming and sharing your expertise with us today. For being here and speaking and staying to be on this panel. We really appreciate it. So right now, I want to ask Karen to come forward, Karen Montez. She's going to come forward. We are going to do a drawing for our raffles. And before we do the raffles, I just want you guys to know that Karen started working with us in what month, Karen? January. And this was her first task, was to put together this program. And I think she did a phenomenal job. So let's give Karen a round of applause. speaking from the perspective of a transplant recipient, I appreciate everyone that you brought forward. And I just really want to say you did an outstanding job. And I've heard nothing but positive feedback. So again, please, please, please fill out your surveys, turn them in. So, because Karen went through those surveys. And that's why this program is better than the last. That was the first thing she did, was read the surveys. So your voice counts. Please fill out those surveys, turn them in. You'll get a little NKFI gift, and we will use that information to make the next program better. Where do we turn them in? At the registration desk in the front. Okay. So we're going to go ahead and do the raffle drawing.
Miss Jackie, would you do the honors, please?
One fell out, put it back in so nobody gets cheated. There we go. Go. All right, round and around and round it goes. There we go. So we're going to draw two numbers. Listen for yours.
857-534. 857-534.
All right. Come on down. Get your goodie basket. Awesome. Congratulations. All right, we're going to spin it around again, and we're going to draw one more time.
857-365. 857-365. Are you in the room? All right.
All right. Congratulations. I was going to say, must be present to win. Right. Okay. Well, thank you all for coming. And the next, the next Living with Kidney Disease program will take place at IIT, so that'll be South, Illinois Institute of Technology. And and it will be September 7th. So we look forward to seeing you there and more of you there. Bring friends. Tell everybody you know this is the place to be. And you guys have a great weekend. Thank you for coming out.